For this afternoon, which is on chronic obstructive pulmonary disease. And it's important because you'll realize if you ever become a practicing physician, a third of your admissions are going to be in respiratory medicine. That's about 33%, and a sizable proportion of them will come in with some or the other form of chronic obstructive pulmonary disease. I'll digress briefly and just move away from the topic. If you look at the atmosphere, do you know how much oxygen content there is in the atmosphere at the moment? Any idea? 20%, isn't it? Excellent. And so if it's like the atmospheric pressure is 100 kilopascals, the partial pressure of oxygen is 20%. And what is it in the blood? Approximately. I don't need an accurate figure. 12, 10 to 12, isn't it? 10 to 12 kilopascals. That's what you get when you do blood gases. So when we breathe in 20 kilopascals of oxygen, by the time it gets into our blood, it drops down to 12. So why does that happen? And what is the reason for that inefficiency? Why does 20% drop down to 12%? Yes, carry on. Exactly. So it's the way the mammalian lungs are designed. So there was a time when the Earth's atmosphere had very high oxygen concentration, maybe 200-300 million years ago, as high as 30-35%, and there was then one of these mass extinction events where it dropped down to about 10 or 12%. That is the time a set of organisms developed a parallel respiratory system, who are called the theropods, mainly a part of the dinosaurs and the birds. And they have a very unique respiratory system because unlike us, they have a dorsal and a ventral air sac. They suck air into their ventral air sac, push it through fairly rigid tubes called the parabronchi, and they collect it in their dorsal air sacs and they expel it. So the main advantage of that is they are not diluting the oxygen they are breathing in, so they can actually maintain much higher concentrations of oxygen in their blood. Now the mammalian lung unfortunately has a to and fro respiration or breathing. That means you suck air in, you expand your lungs, pull air in into your air sacs, and then you squash and push all the air out, and that puts it at some disadvantage. Firstly, you can't have a rigid system, so all your airways are fairly flexible and have to have some amount of floppiness. Right? 2, you cannot completely deflate the system, otherwise you won't be able to reinflate. So there is always some air left behind, and when you inhale, the residual air in the alveoli, or the dead space air as it's called, dilutes whatever you breathe in. And then there is some inefficiency, as you said, in gas exchange, and that is one of the reasons why it's hard to get our PO2 above 12, 13, 14 kilopascals at best. It also has a bearing on the topic that we are going to discuss today, which is chronic obstructive pulmonary disease. Very common pathology. Of late it has become popular as COPD, but if you historically met patients in clinic, they only mentioned it as chronic bronchitis or emphysema, or mainly emphysema. Now it's a condition which leads to obstruction of the airway, and if you remember, we discussed asthma 2 weeks ago. The mechanism is similar as well as different, and we'll come to it. The main problem is it gets worse with time, it progresses, and with each passing year the lung function tends to decline, and that is essentially because of the inflammation in the lung and breakdown of the lung tissue and the airway becoming floppier and floppier. So when they're exhaling, the airways narrow down and shut earlier and earlier in expiration. Secondly, because it's not largely because of bronchospasm or tightening of the smooth muscles, and it is because of floppiness of the airways, it's not a reversible phenomenon. Once the lung has lost elasticity and become floppy, it has lost its elasticity and become floppy. So there is some reversibility because of smooth muscle spasm, but the primary thing is it doesn't reverse and doesn't fluctuate from within the day, from day to day, or over a period of time. So if you were to sort of do one of those home peak flow analysis or morning afternoon peak flows, you won't see much of a change. And lastly, it is mostly found in smokers. It's very common. It is emerging to be one of the top causes of mortality and morbidity according to WHO, and because it's getting more and more frequent, not only in developed but also in developing countries where the tobacco industry is really pushing its product and expanding its market. In the UK, they say there's about 1 million people that suffer from COPD, but mind you, this is an underestimate. Most smokers don't see their GPs early enough. So there is a lot of underestimation of what's going on, and by the time they come in with a major infection or severe breathlessness, that's when we tend to pick them up. About 30,000 deaths, takes up about 1 million bed days, which is huge in terms of bed days, and the cost to the NHS is 1 billion a year. 90% of that cost is because of hospitalization. So if you can prevent people from worsening, progressing, having flare-ups, getting into hospital, you're going to save, I won't say 90%, but a sizable proportion of that. So the aim in managing patients with COPD is how to keep them out of hospital and preventing them from flaring up. Now, it's an umbrella term. I mean, these are historical terms. Emphysema, which is essentially a pathological change in the lung whereby the air spaces lose their integrity. Chronic bronchitis, it's a histological change in the airways. There are also other changes that you see with COPD, which is included on the umbrella, because smoking also affects the blood vessels that flow through the lung and causes them to narrow and thicken, and there is pulmonary hypertension. There is also an impact on bones and muscles. So the entire collection of all these effects together, it also has an effect on the heart, comes under the term of COPD. Why did we use this? So that we can gather together all the patients with their myriad manifestations under one umbrella, so that we can have a national and a global strategy for how we manage this condition. So patients fall into various spectrum. They may predominantly have emphysematous change in their lung. They may predominantly have chronic bronchitis as historically recognized. They may just lose weight to start with, or they may just have problems with gas exchange without significant, so all permutations and combinations are present. I would, traditionally we are taught that you have what are called pink puffers who are emphysematous and blue bloaters who are more chronic bronchitis with heart failure, and people fall within a spectrum of that. I think it's more a combination of these and the other things I mentioned. So pathologically, emphysema is essentially destruction of the alveolar air spaces. So the alveoli, if you look at it, typically looks like foam, and I think they've likened it to a bunch of grapes. Now, because of intense inflammation, the walls of the individual air sacs or alveoli break down, and they fuse to form larger air spaces. And these air spaces could be more than, say, a few millimeter to up to huge, enormous bullae as big as 10 or 15 centimeters across. So essentially, the lung starts to look at, if you've seen a gross specimen, I don't know, but they start to look like a bath sponge instead of foam. And that's how I tell my patients. I don't have a bath sponge in clinic to demonstrate, but that's how it starts to look like. The mechanical problem with this is that the alveolar walls are where the blood vessels run, and there is a loss of capacity. Firstly, you lose the surface area, and the loss of capacity to absorb oxygen through the lung. Secondly, the density of alveoli provides some sort of elastic framework or scaffolding to hold the lungs together, to stretch the airways open. And once you start losing this, the lungs become kind of flabby and floppy, and the airways lose their elasticity. Mind you, most airways beyond bronchi and certain bronchioles don't have any rigid structure in them. They don't have any cartilage. They do narrow down when you exhale, and they do stretch open when you inhale, and that phenomenon is exaggerated. So I think we've just discussed that. So what happens when the airways start to shut down when you're exhaling is you're not able to exhale to what is called the residual volume. So if you come down and exhale completely, that point becomes higher and higher. So your exhalation stops at a much higher lung volume and your lungs keep overinflating. So your next breath is that much shorter. Right? At the moment I have a certain inspiratory capacity from my complete exhalation to a full inspiration. That's called my inspiratory capacity. But as my residual volume goes up and I am exhaling to residual volume earlier and earlier, that becomes shorter and shorter, and I'm starting to breathe at a much higher lung volume, and that puts me at a mechanical disadvantage. And that leads to overinflation of the lung, and that's a chest X-ray of how an overinflated lung looks. So the lungs look, it's not projecting well, and you will have an opportunity to look at lots of emphysematous X-rays and scans. The lungs look much darker. This is the heart. The cardiac shadow looks much narrower because the lungs have grown and encroached on the cardiac borders, and the diaphragms, instead of being dome shaped, look much flatter. Now when we breathe at rest, we largely use our diaphragm, and then we start to exert a bit more. We start using our intercostal muscles, and then finally at peak respiration we are using our accessory muscles of respiration, which is like the trapezius, the sternocleidomastoids, the pectorals, the latissimus dorsi, the abdominal muscles. In a hyperinflated lung where the diaphragm has already moved down and has sort of completed its excursion, and the rib cage has already moved out, and there is a mechanical disadvantage with the intercostal muscles, you are relying on your accessory muscles to compress and expand your lungs, and that's hard work, and that hard work, or the work of breathing, makes people breathless. Most people don't understand why they can't breathe in, because their lungs are overinflated, and it's hard breathing in from there because there is only so much you can expand this system, and it's reached its limit of mechanical function. So chronic bronchitis is the second significant change that takes place in COPD, and that's largely because of direct irritation as well as mediators released largely by neutrophils, and there's an intense inflammation in the airways. The number of mucus glands within the bronchi and the bronchioles increase. They produce thick mucus, and there is a degree of muscle spasm because of which there is narrowing. The mucus tends to plug the lumen, and you tend to breathe through narrow air tubes. So the effect is same as happens in asthma, that you're wheezy, you're struggling to push air out of your lungs, and if your exhalation takes 3 or 4 seconds in patients with COPD, it's often prolonged because they're trying to empty the lung out against narrow air tubes. It's like breathing through a narrow straw, breathing out of a narrow straw. It's very similar to that. That also contributes to the work of breathing. So as I mentioned earlier, smoking is the major factor associated with COPD, but there are others. I mean, there's a condition called alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is needed to protect the lung from enzymatic damage, and these patients often develop quite intense or severe emphysema, if they have the full deficiency, that is, quite early in their life. And obviously if they smoke, the damage is that much worse. They often have other manifestations like those in the liver and the pancreas, and it's a small subset of very specialized patients that are best managed in a specialist center that deals with the condition. There are some occupational exposure as well which play a factor. Coal dust, yes, and more commonly, people who work with cotton or sugarcane can develop similar inflammation and emphysematous change. Pollution may play a role, but the evidence is not that robust. So 15% of smokers get COPD. That doesn't mean that 85% of smokers go scot-free. They develop other things: stroke, heart disease, various vascular conditions, other cancers. And obviously, I mean, there is some genetic susceptibility. I mean, otherwise you can't explain why only 15% of smokers develop it. So what are the symptoms? The symptoms are related to the anatomical change. I mean, they will, because of the bronchial involvement, they will have cough, they'll have sputum production, they will complain of wheeziness, and they'll complain of breathlessness. Most patients with COPD will usually present with worsening breathlessness, initially doing stairs and slopes, carrying in their shopping, lifting objects, putting them high up on a shelf, and bending down to tie their shoelaces. Those are the activities they first start noticing breathlessness in, and then it gets worse and worse. They're breathless walking on the flat, eventually becoming housebound. Some people go on to sort of complain of increased sputum of very large amounts and develop bronchiectasis. They tend to get very frequent chest infections, especially through the winter months. They will often say, I have constant infection in the winter months lasting 2-3 months throughout the winter period, and it has gone on for a year or two. That should alert you in a smoker that they have significant COPD and you should investigate. And then these exacerbations become so frequent that they end up in hospital. I mean, in our hospital we get about 500 admissions every year. The Milton Keynes is not a huge place. 500 is quite a large number, and they spend anywhere between 4 to 5 days to up to 4 weeks. So the various ways of subclassifying these patients to assess their severity and their functional status. One which is widely accepted is the Medical Research Council dyspnea score. It's quite easy to remember if you have to, but I'm sure you people have to remember a lot of these scores. So the grade 1 patient is only breathless with hard exercise. In grade 2, it's usually slopes, stairs, especially when they're hurrying or walking up a hill. Grade 3, they get breathless on a flat level surface, but they're not restricted. They tend to fall behind their peers. Grade 4, they manage about 100 yards. So that's enough to let them go out, to go to the local shop, buy their packet of cigarettes and whatever they need for the day and come home. But they're getting increasingly restricted in their day-to-day work. I mean, going to a job is out of the question for these people. And then you have a large number of grade 5 patients. I say large number because I'm in hospital and mostly see grade 4 and grade 5 patients, so I'm biased. These are the homebound ones. I mean, they're so breathless they just travel room to room, maybe a few yards outside the home, and those are the ones we largely focus on when you're in a hospital. So their activities of daily living is severely curtailed. They can't wash or dress themselves even, and they often need carers to look after themselves. They've lost their independence. Are there any specific signs? Yes. Traditionally taught, they tend to have pursed lip breathings. They often narrow their lips and breathe out through a narrow opening in their mouth, like that. That tends to increase the pressure in their airways. When you're expiring, if you narrow the exit, that will increase the pressure in their airways. Keep the airways open as long as possible so as to allow the lung to empty itself out. It is a tactic they use to reduce the residual volume and to empty out the lungs to the maximum. Yeah, they're often visibly breathless. They're using accessory muscles of breathing, so you can actually see that their sternocleidomastoid and trapezius stand out quite a bit. And the other thing I've noticed, they would often lean, and by leaning they would anchor their arms so that the muscles that are attached to the arm and the chest wall could be more effectively used. I mean, everybody uses that technique, even athletes do that. That is to help expand your chest over and beyond its physical capacity. They can be hyperinflated, especially the emphysematous one. Their anteroposterior diameter of the chest increases. So if you look at them from the side, or if you happen to see their CT scan, instead of the chest looking fairly flat, it looks fairly round and barrel shaped. But it only indicates that the lungs are inflated and the rib cage has moved from its resting position. And are there anything to examine? Yes. If you listen to the chest, you may hear wheezing. or you may be barely able to hear their breath sounds. I mean, if you put a stethoscope to the chest, there are normal breath sounds to hear, but in patients with COPD with such little alveolar space and such narrow airways, the airflow is so slow, it's very hard to hear sometimes. And that's the most consistent finding you will see. You might be able to, on examination, see that they are cyanosed. You can elicit in some patients signs of carbon dioxide retention. Mainly they have congested eyes, fairly dilated veins on their face, and they may have a flapping tremor, but that's mainly in the acute setting. And they may have signs of right heart failure, which essentially manifests as a heave over the chest because of the right ventricle trying to squeeze blood through narrow pulmonary vessels, or there are back pressure changes leading to swelling over the body or in the lower limbs. So such patients will point out to you that my legs have started swelling, I'm very tired through the day, and often sometimes get epigastric pain because of a congested liver, and they are going into heart failure. How do we assess COPD? Simple test, simple, reliable. You can use it by the bedside, you can use it in clinic. Most of the equipment nowadays is miniaturized. I think it's quite wonderful if you know how to do a spirometry accurately and interpret it. And what the spirometry measures are two things. One is the forced vital capacity, which is the total amount of air that you blow out of your lung, and more importantly, that volume of air that you blow out in the first second. And you should be able to blow out 3/4 of the air in your lung in the first second, but if it's less than 70%, that means the airways are narrow and it's taking longer and longer for you to exhale. And by looking at the FEV1 divided by FVC and the FEV1, you can sort of classify COPD into mild, moderate and severe patients. So over a period of time, patients' FEV1 declines compared to someone who's never smoked. This is a famous chart by research by, I think, someone called Professor Pito and Fletcher. Now, Professor Pito is important because Professor Dahl and Pito were the first people to demonstrate that smoking is injurious to health. And that was a landmark paper, and Prof. Pito went on to do more study on it. This one demonstrates that whenever you give up smoking, it is beneficial, it adds to your years of life, improves survival. We use it all the time to show to the patients. So how do we, as I was mentioning, subclassify patients of COPD into mild, moderate and severe? There are nice guidelines. There are 80 American Thoracic Society guidelines. There are gold guidelines. They vary slightly, but they're all sort of gradually coming towards the same set. The old NICE guidelines said if the FEV1 is 50 to 80% of predicted in a patient whose FEV1 by FVC ratio is less than 70%, then they have mild airway obstruction, and then less than 50% is moderate and less than 30% is severe. I quite like this classification, but of late what they have done is they've shifted it, and they've said anyone with a reduced FEV1 by FVC ratio who has an FEV1 more than 80% has mild obstruction, and then this becomes moderate, severe and very severe. So that is the latest. But it's only, believe me, airway obstruction is only one way of assessing your patient. I mean, that's not the only way. You might find people with FEV1 of 30% completely different. One is homebound, the other is still working. So it's, as I said, it is only one of the dimensions of assessing your patient. The MRC scale is the other dimension, and there are many other such dimensional tools you can use. So how do we diagnose COPD? They're not hard to miss. They're smokers, they're often middle-aged or more. They will come in complaining of worsening breathlessness, and they will have cough, phlegm, wheezing. They will have history of winter bronchitis, and you examine them, you find hyperinflated chest with fairly quiet lungs or wheezing. You do a spirometry, you demonstrate obstruction, and you have made a diagnosis of COPD. It's much easier than, believe me, much easier than some asthmatics. This is a comparison, and again you'll come across this quite frequently. This is a comparison with COPD and asthma. More useful in primary care than in secondary care. I think by the time they come to secondary care, it's quite clear what they have. I mean, the frequency of smoking is more in COPD. You know, it's rare in the younger people. Phlegm is common in COPD because of chronic bronchitis. The breathlessness is not periodic or episodic, but progressive and persistent. Nocturnal symptoms are more common in asthma, where they wake up in the evening or night time or early in the morning with cough and wheezing. And same with diurnal or day-to-day variation. That's quite rare in COPD patients. It stays about the same. It is persistent. It progresses, and invariably the patient deteriorates over a period of time unless expertly managed. Other investigations are helpful. In fact, I would say most useful. A chest X-ray is essential not only to look for hyperinflation. I also use to look for things like are there any bronchiectatic change? Is the heart enlarged? Is there any other shadow in the lung? For example, there have been smokers. Is there a tumor? Is there any other lung pathology that I have, I think that this is COPD, but the patient may have something else. A CT scan can help look at the emphysematous change. It's predominantly in the upper parts of the lung, but severe emphysema you can start thinking of in certain patients, especially in presence of emphysema or what are called bullae or large air spaces. Can they be sent for surgery? It also helps, look for changes of bronchiectasis, rule out other diseases just as in a chest X-ray. We use blood gases to look for respiratory failure. As I was mentioning, normal PO2 is 10 to 12. As respiratory failure sets in, the PO2 falls, and you may have someone with a PO2 of 9, 8, 7. So they are in type 1 respiratory failure, and eventually, as in COPD, type 2 respiratory failure sets in. When they can't clear out the stale air, the carbon dioxide builds up and the PCO2 starts rising, and that's important bit of information. This is another dimension in which you can assess your patient. Is the patient in respiratory failure? What is the severity of respiratory failure? And whether the patient is in type 2 respiratory failure. And then in the younger patients, those below 50 or with family history, you must do an alpha-1 antitrypsin assay. Rare, but if they have, they need specialist help. So how do we manage patients with COPD? There are two aspects to it. You manage the stable patient. For example, when I see patients in clinic, they are stable, they are not flared up. We optimize treatment. And two, managing exacerbations, which is completely different. Yeah. In managing stable patients, there are a lot of components. So we have something called the NICE, the National Institute of Clinical Excellence, and even prior to that, globally, there were a lot of guidelines which set out some priorities for patients with COPD. One was making a robust diagnosis based on spirometry. Never label anyone having COPD without having done a spirometry. There are patients who have smoked, who have emphysema, and who have completely normal spirometry, and I just label them as smoker with emphysema. I don't label them as COPD. I think that's the right thing to do. So, second, smoking cessation, top priority, because that is scientifically proven to have an impact on the disease outcome, the severity, the mortality. 3, pulmonary rehabilitation. So when we assess patients using the MRC scale, and we have patients who are breathless, and as their level of activity is getting curtailed, they are struggling on stairs and slopes, that's the time to move in and subject them to an exercise, a dedicated exercise program tailored to their needs called pulmonary rehabilitation. 4, which another top priority is called effective inhaled medication, bronchodilators, and also antimuscarinics and steroids. So these are the effective inhaled medication. It's not enough to prescribe, it's also to ensure that the device is able to deliver the drug into the lung. So because mind you, Most of them have overinflated lung, very little power to suck in, and breathless, frail, underweight, often struggle with their inhalers. So inhaler technique training is important. Mucolytics, there have been studies, few, but there have that show that using mucolytics can reduce frequency of exacerbation. Patients should have a trial of mucolytics to see if they benefit from it, if it helps sputum clearance or helps dry up their sputum. And in that case, I'm sure it is worth continuing with mucolytic therapy. Apart from mucolytics as tablets, we also use what are called xanthines, which I'll come to later. Diet is important. It has, normal BMI or body mass index is between 20 and 25. That's your height, your weight in kilos divided by height in meters squared. Patients with COPD can lose weight, and that is a bad sign. It indicates that the inflammation is so intense that it is having a systemic effect. So they're losing their bone mass, so what's called osteopenia. Smoking causes osteoporosis, it's known. So, and they're losing their muscle mass, which is called sarcopenia. If you look at them, you will notice they've got quite marked quadricep wasting. If you lose muscle, you can't get out of a chair, you can't do stairs, because proximal muscle helps you stand up, walk, do stairs, and it puts an enormous load on the respiratory system, breathing using inefficient muscles, because at the end of the day, the respiratory system is largely designed to deliver oxygen to the muscle and wash away the carbon dioxide that it generates with physical work. In COPD, that's completely messed up. So there are two ways of dealing with it. One is pulmonary rehabilitation, and second is diet. So anyone with a BMI less than 20 is in trouble, and I tell them that you're in trouble if you don't make drastic changes to your life. You're going to progress. It's well proven through research that they have very high mortality. So the only way to drag them back is to get them to stop smoking, refer them to a dietitian, get them to put on weight, and if they do, that is a positive sign. They're prone to exacerbations, so preventing infection is important. So they need a pneumococcal vaccine and they need annual influenza vaccination. There is enough evidence to show both of them are effective. As the disease progresses, they tend to go into respiratory failure, and such patients need to be carefully assessed for long-term oxygen. And lastly, in some carefully selected patients, especially those who have severe emphysema in their upper lobes or they have bulla, you can send them to a surgeon for what is called bulectomy or lung volume reduction. The logic is, if you take away the non-functioning part of the lung, the functioning part of the lung will somewhat inflate and take up that space. The inflation of the lung will allow the air tubes or the bronchi within the lung to stretch open, and it will overall deflate the chest wall, thereby restoring their residual volume. So it only works in carefully selected patients. Unfortunately, it's not a magic. So smoking cessation remains important. There are smoking cessation services run by the councils everywhere and primary care, and any time that you come in contact with a patient who's smoking, either in a GP practice or in your clinic or in hospital, it is an opportunity to advise them about smoking cessation and bring them in contact with a smoking cessation advisor, who then goes through with them the advantages and provides them nicotine replacement therapy. So it has to be opportunistic as well. In my experience, increasing number of people have successfully given up smoking, I think, and that's quite a success. Most smoking cessation advisors obviously try to assess the patient's behavior and work on their behavior and try and get them off cigarettes. Bronchodilators that are the next group of drugs we use. There are largely of two groups. one that works on the cholinergic system and one that works on the adrenergic system. And the ones that work on the adrenergic system stimulates the adrenergic system, and they're agonists. They're specifically agonists of the beta receptors in the adrenergic system, and they are beta 2 selective. That means they have less effect on the heart and primarily on the lung. It's not that it's exclusive. I mean, high doses of beta 2 agonists will also stimulate the heart. They work on what's called the adenylate cyclase, which converts AMP to cyclic ATP to cyclic AMP, which has its impact on what's called the protein kinase A, which has its impact on myosin light chain kinase, through which muscle contraction takes place and muscle relaxation and contraction takes place. So drugs like salbutamol induce muscle relaxation through this pathway. There is a risk that as with all adrenergic drugs, that the receptors can get down regulated and the lung can get less sensitive to salbutamol and drugs like that. So normally we use salbutamol and terbutaline as short acting, and formoterol and salmeterol as long acting beta agonists. They have side effects. As I said, they're largely cardiac, and they cause increased heart rate, tremors. Patient can have that feeling of anxiety, palpitations, and they can drive potassium from the extracellular fluid into the cells and cause hypokalemia. That can be a problem in your patient, especially someone who is breathless, not eating and drinking and getting dehydrated. So these are the things to be aware of. You need to warn the patient. The next group of drugs are called antimuscarinic agents. They block the cholinergic pathway. Now the cholinergic receptors are of two types, nicotinic and muscarinic, and only the muscarinic ones are peripheral. And of these, there are three. There's M1, M2, and M3, and M2 and M3 receptors are peripheral. Antimuscarinic blockers tend to work on the M2 and M3 receptors. Unfortunately, the M2 receptor is actually an antagonist of the pathway, and blocking it actually causes muscle spasm. But predominant action of the antimuscarinic agents, it should read ipratropium or Atrovent, is on the M3 receptors, and it works on the M3 receptors to induce muscle relaxation. The more selective long-acting antimuscarinic agents which have become popular, like tiotropium, tend to work selectively on the M3 receptors, and they're hence more effective. Antimuscarinic drugs have lots of side effects. They're like atropine, and anyone who has seen atropine poisoning will never forget. So they tend to get, in our time they used to be like a little saying like you're dry as a bone, blind as a bat, mad as a March hare. Those are the signs of atropine poisoning. So they can cause dry mouth and cough, sore throat, upper respiratory irritation and nausea. They can speed up the heart because of vagal blockade and induce a variety of arrhythmias as well, cause difficulty in passing urine, and can be a problem in your elderly patients who have all got large prostates. So it's not a small problem. Patients with poor mobility already have constipation, and this drug makes you even more constipated. One thing to watch out for and to be very careful about is precipitating a glaucoma, and in anticholinergics are known to precipitate acute glaucoma, narrow angle glaucoma, so you need to be very, very careful about that. But largely safe drugs, as long as you're aware of the side effects. So those are the bronchodilators we use. The third one we use is the methyl xanthines. They work through the phosphodiesterase pathway. It's not here, and I'll come to this slide later. And ultimately, again, it's through a cyclic AMP mechanism. Corticosteroids are the next set of drugs. They're widely used in medicine as anti-inflammatories, and they're used for a very wide variety of condition, and they are used as anti-inflammatory in steroids, in COPD. the evidence for use in COPD is quite weak because the predominant inflammation is through neutrophils and alveolar macrophages, on which corticosteroids have very weak action. They're anti-inflammatory, they are intracellular, they cross the nuclear membrane and enter the nucleus, and they bind with their receptors, and they work at the level of the DNA. So they induce translation of anti-inflammatory molecules, which then suppress the inflammatory process in the airways. They are predominantly recommended in patients with exacerbation, because the only evidence, as I said, is they reduce the duration of exacerbations and they reduce frequency of exacerbations. So if they're being taken as inhaled medication, they're used in patients who exacerbate frequently and have severe reduction in lung function. And if they're used as tablets, they're only used in acute exacerbation for a short time of anywhere between 5 days to 2 weeks to reduce hospitalization and length of stay. They have huge number of side effects, and if I go back 10 to 15 years ago, oral steroids and long term used to be used quite frequently in patients of COPD. They used to often end up with very thin skin and bruising, and the third thing I used to see very frequently is osteoporosis. And with osteoporosis, it hits your vertebral bodies and the vertebral bodies start crumbling. So in a patient who's got overinflated lungs, if his spine starts to collapse, it's like it's a double whammy. So you just crawl under the bed and overinflate your lungs and you try and breathe through it. So you're restricted and obstructed. So they used to go into respiratory failure very quickly because they could hardly move their chest wall. Fortunately, we have moved away from that trend and we are mostly using inhaled corticosteroids, and that too, the trend is slowly moving away from that. The other effects, head to toe, they cause mental changes, they cause cataracts, they can cause glaucoma, they can chronically suppress the adrenals and induce diabetes. Often patients put on weight and it leads to a gain in truncal obesity. So you're redistributing your fat from your peripheries to the center and you're actually causing muscle loss. So you're causing exactly what the patients of COPD shouldn't have. So they end up getting more and more deconditioned and breathless, and that can be a problem. They're known to cause GI symptoms as well. In a small subset of patients who take oral steroids quite frequently, lose weight, and if you ask them and they say, we have lost our appetite and we feel nauseous all the time. And when you actually look into their stomach, they've got gastric ulcers from steroids, and people think they're losing weight because they've got something in their lungs or they've got COPD. So that is a pitfall with steroids people often miss out on. So mucolytics are used in carefully selected patients. Mucolytics tend to break up chains of protein in the mucus because they break, mucus protein has cysteine, which has, I think, a sulfur group, and the sulfur groups cross-link with each other and hence thicken the mucus, and mucolytics can break that down. They also have an antioxidant effect, and there may be a role in reducing inflammation through their antioxidant action, which has not been clearly defined. Now, the key message to take home about drug treatment is that drug treatment is a small part of COPD. Pharmacological treatment is needed, but it is not the be all and end all of COPD. So non-pharmacological treatment plays a huge role in management, and that's important to remember. What is more important is pulmonary rehabilitation. There has been some papers that have shown that what are called quality adjusted life years. Pulmonary rehabilitation makes a positive contribution to quality adjusted life years at a very low cost. Compare that with, say, treating something like multiple sclerosis, where you spend hundreds of thousands of pounds. Here the investment is very small. It's a small team of dedicated physiotherapists with dietitians. There are 2 or 3 components of it. There is a lot of education, there is dietary advice, they are taught energy conservation technique, and Then obviously the physical therapy, which consists, they're trained how to breathe through pursed lips, how to lean and breathe more effectively to empty their lung out, how to clear the lung out of phlegm. Then there is exercise training and strengthening of the upper body muscles, which they use as accessory muscles of breathing, as well as training of the leg muscles, because those are the ones that consume most oxygen and generate more carbon dioxide. So if there is muscle training, there is reduction on the demand on the lung. So if you generate less carbon dioxide, you will have to breathe it out less. So it's a multi-component, multi-professional session. They last for anywhere between 6 to 12 weeks, and the effect lasts as long as 18 weeks. And what we have done in Milton Keynes is we have also got similar provision in the community, so that after the hospital pulmonary rehab, they have continued rehab closer to home, so that the benefits are maintained. So if the patient can be physically maintained and kept mobile, I think there are huge benefits, because it encourages through exercise muscle gain, bone mass gain, and gives them the level of independence that helps them overcome depression and all the other things that come from loss of independence. Oxygen therapy, and it's important because it's not just because of loss of alveolar walls that people can't absorb oxygen. There are actually structural changes in the pulmonary vessels that go through the lung. They undergo vasospasm, the walls of the endothelium are thickened, and overall transfer of oxygen from the air sac into the blood is diminished. I always, when I do lung function, I always ask for a transfer factor, because in many patients you're not sure whether they have COPD. If they have a low transfer factor, which means the speed at which oxygen gets transferred from the air sac into the blood vessel, it is a very robust indication that they have COPD. Not everybody needs oxygen. There is no role of oxygen when you're breathless. It's not a drug for breathlessness. It is a drug to maintain their oxygen levels such that it puts less demand largely on their heart and other vital organs. It's to protect them and prevent them from heart failure, which increases their mortality. All the studies that have shown, that have been done, and they are very limited, that long-term oxygen protects the heart and other vital organs and reduce your mortality, and that's the only benefit, and that's why it is used. There is a cutoff threshold for it, which is the ABG has to be less than, the PO2 has to be less than 7.3 kilopascals on 2 separate occasions, 4 weeks apart, when the patient is not exacerbating. In a certain subgroup of patients, this threshold is raised to 8, and that is for people who have already undergone changes in their heart related to COPD. So they have pulmonary hypertension, they have congestive cardiac failure, or if they're becoming polycythemic, they have peripheral edema, or they have persistent nocturnal hypoxia. So you may have to do a nighttime oxygen study. These are the ones that benefit from a higher threshold of oxygen. Once they are on oxygen, it has to be taken 14 to 16 hours a day. It's given through a device called oxygen concentrator, which sucks oxygen in from the environment and uses zeolite to absorb of the nitrogen, thereby enriching the oxygen. So it has its limitations. If you increase the flow rate through the machine beyond a certain point, it's no more effective, and you often have to put 2 concentrators in series to concentrate it to that level. You need to be careful, because if you oxygenate a person who is at a risk of retaining carbon dioxide, they may become hypercapnic and they may go into type 2 respiratory failure. That can happen very quickly, within minutes, and these people can end up in A&E in type 2 respiratory failure. So we run oxygen clinics, we check the PCO2, we give oxygen, we repeat the bloods to check if the PCO2 has gone up, and if it hasn't, well and good. What do you do if the PCO2 goes up after giving oxygen? Say you've corrected the oxygen and pushed it to 9, and the PCO2 at the same time has gone up to 7. Difficult. We then send them to specialist centers where they are given home mechanical ventilators. So they use what is called a BiPAP ventilator at night to clear out that carbon dioxide. And because these people are living better and longer than the cohort of patients who need ventilation at home is also gradually increasing. There's an expanding pool of patients. People also have ambulatory oxygen, and these are the people who desaturate on exertion, and on giving oxygen their exercise tolerance improves. That means we make them walk for 6 minutes without oxygen, and we measure the distance. We give them oxygen and make them walk for 6 minutes, and if the distance increases, we give them ambulatory or portable oxygen. But you need to be careful, because if it reduces the distance because they have to lug an oxygen cylinder across, it defeats the purpose. So often they have what's called a small liquid oxygen flask that is very light, no heavier than say a lady's handbag, couple of kilos, and they have a tank at home from which they recharge that little flask, and it gives them a couple of hours, sometimes 4 hours outside their home, and adds to their independence. It's a great luxury when you can go out and do your own shopping, when you can't do it without oxygen. And lastly, as I mentioned, lung volume reduction. Carefully selected patients, you removed emphysematous parts of the lung and allow the rest of the lung to expand. You can take the lung out surgically. You can also block the airways off which subserve the damaged lung using valves. These valves only allow one-way flow of air, so that they don't allow any air in, they only allow air out, and that part of the lung collapses, and the healthy or the relatively healthy lung expands and takes off that space. So the patients are less hyperinflated, their airways are stretched open, and they function better. There are some reasons why it only works with few patients, and more popular across the Atlantic than in the United Kingdom. Some of my patients have had to undergo lung transplant because they've had severe COPD at a very young age. So key message is that, as you saw with COPD, most important, pharmacological management is only a small part of it. So as a doctor, you can do only so much. You need a multidisciplinary team. You need physiotherapists, occupational therapists, dietitians, specialist nurses, smoking cessation advisor, and you all have to work together as a team to provide what's called this care bundle, and you have to respect what the expertise they bring in, because you can't be an expert of everything. They specialize as well. Acute exacerbation can be tricky because they exacerbate from various reasons. It could be a viral infection, it could be a bacterial infection, it could be CO2 retention because they've had too much oxygen and they've ended up in hospital. They're more breathless, they can be agitated, hypoxic, hypercapnic, drowsy, or they may have a full-blown infection with pneumonia and be septic. So you have to quickly assess and see what is going on. Are they wheezy, how hypoxic they are, how hypercapnic they are, have they become acidotic, have they become septic, and you have to manage accordingly. So they need controlled oxygen therapy to prevent CO2 retention. They are given urgent nebulizers, intravenous or oral steroids, appropriate antibiotics. If they have a temperature, their CRP is up or they are bringing up copious amounts of purulent phlegm. Sometimes we use IV aminophylline in carefully selected patients, and they all have blood gases. I think nowadays everybody has a blood gas to make sure that they are not retaining carbon dioxide and have become, because if the carbon dioxide goes up quite quickly, the pH is going to fall because the body hasn't had a time to compensate for that shift. It hasn't been able to adjust the bicarbonate level accordingly. Once they become acidotic, your muscles start to malfunction and you tend to breathe that much worse, and you spiral down rapidly into a severely acidotic. So you will see a patient whose carbon dioxide level is 13 instead of 6 and a pH of 7.23, and they're in deep trouble, and you get them onto non-invasive ventilation immediately and then get ITU involved. So that amount of alertness you need to have. So to summarize, it's a common condition, as I mentioned. A third of your admissions are going to be respiratory, and out of them 1/4 are going to be COPD. It's preventable because it's largely induced by smoking. So whenever you have an opportunity to get someone off cigarettes, you must, because it's not reversible and it's relentlessly progressive. you don't make a diagnosis unless you have a robust spirometry, a post-bronchodilator spirometry when the patient is well, along with other signs and symptoms. Again, reiterate, smoking cessation is key. And once the disease sets in, you have to get the patient through a multidisciplinary team consisting of appropriate inhaled therapy, pulmonary rehab, dietetic involvement, assessment for oxygen, management of infections, all of it. It's a whole package, and hence an MDT approach is essential. I mean, the primary and the secondary care with all its resources need to work together very closely to provide a successful COPD care. Otherwise, patients will exacerbate, they'll end up in hospital, and the £1 billion that I mentioned, 90% of it is because patients end up in hospital because they're badly managed, not diagnosed early, not managed with a multidisciplinary team, and not kept in stable, fit and functioning. I think that's it. Thank you very much. Do you have any questions?